In my experience as a personal trainer and physical therapist, the condition I've encountered the most by far is low back pain. It is not always the primary reason someone comes in seeking therapy, but it is something I often screen for, as it is an extremely common secondary condition that can change how I need to approach my patient's care. When I was a PT student, fresh into my first outpatient ortho rotation, I had the opportunity to work with some folks who had some pretty severe low back pain that was deeply entangled with other conditions that they had. I learned quickly that no two patients will ever present exactly the same, and because of this, my exercise programming needs to be specific to each person that I assess. It's really easy to get into the weeds as a new PT when you're trying to find the root cause of the pain, and it's hard when you're not getting expected results like you might with other more straightforward injuries. So I developed a basic clinical framework loosely based on the ICF model that we all learned in school. This framework is based on my clinical experience and not something I would consider to be the pinnacle of PT. With that being said, let's get into it. I'm going to break my framework down into 5 components for now. Your didactic education is usually pretty good at getting you ready to tease out why something is not working the way it should. As a DPT, this is going to be your strong suit coming off of your recent education. Use those skills and improve them. Sometimes patients will come in with a diagnosis already. I strongly recommend to keep it in the back of your mind as a data point. You need to see the patient as they are in front of you, not as the diagnosis that was paired with them. This concept is crucial to prevent bias, which can ultimately lead to inferior outcomes. These are some important notes that will help you build your case before you even touch the patient. The date that the pain began, mechanism of injury, patient's profession, hobbies, and activity levels, their past medical history, the time of day symptoms affect them the most, movements that aggravate symptoms, most alleviating factors. Knowing the answer to these questions can help you decide if you need to screen for more serious medical conditions and which tests and measures you can employ to be as specific as possible. Depending on the acuity of the injury and how sensitive the patient is to provocative testing, you may be doing much more harm than good if you just go straight into your special tests. Always start as far away from the point of pain as you can and work your way in. This serves you in 2 ways. You can collect data about potential contributing factors to their condition while keeping their symptoms lower, and you begin to build their trust. Once you find out where their limitations in body structure and function are, you should have a much better picture about what's going on. If you still don't feel like you've gotten down to the root cause, don't worry. You can and should assess again later on down the road as they progress through therapy with you. At this point, you should have had a conversation about their prior level of function and their goals with therapy. This is a great time to decide on an outcome measure to implement. Day 1, if they are really sensitive, I like to start with questionnaires that I may even weave into the intake itself. These are great to help your patient come up with aggravating factors without being put on the spot. It's hard to think straight when you're in pain, and it's even harder when you're talking to a stranger you don't really trust yet. This is where you're going to get your exercises from too. For example, let's say your patient looks at the Quebec Back Pain Disability Scale and goes, "Oh yeah, bending over to clean something's the worst. I feel like if I bend too far, I might just get stuck there." Well, you can turn this into a goal now. If they're not too sensitive, you can even have them try to bend over and see how far they can get without exacerbating their symptoms. Even if this sucks for them to experience, this could at least be a good moment to harken back to later on to show them how far along they've come once they've made some progress. Many patients coming in with back pain will look at you funny if you ask them what alleviates their pain. Some might tell you they take an anti-inflammatory, use a hot pack, and some might even be using E-stim at home if you're lucky. They may be able to recall a sleeping or sitting position that's comfortable for them, if even for a short time. Build on that and the information you cultivated during the previous 2 steps to come up with strategies to help keep their pain low. You always want to start with positional decompression if possible to help unload the stressed tissue and reduce muscle guarding. This will involve getting them into a position of a relative comfort, or specifically a position that reduces nerve compression or puts affected tissue on slack. Typically, patients with low back pain will broadly fall in one of 2 categories: flexion bias and extension bias. Patients who are flexion biased tend to feel more relief with their spine rounded or pelvis facilitated into a posterior tilt. These patients will tend to like hook lying positions best and it may even be more comfortable to prop their thighs up with pillows to further reduce spinal compression. Side lying preferring one direction over the other is also common. Make sure the spine is aligned from head to hip and place something between their legs to avoid excessive spinal rotation or side bending, which may aggravate affected tissue. Patients with extension bias are a bit more rare in my experience, if we are strictly defining them as individuals who prefer a straight spine with pelvis facilitated into an anterior tilt. These people may prefer lying flat on their back or prone. Remember that back pain, especially in the acute and subacute stages, can be a bit volatile, so your patients may present with different preferences one day to the next. Keep an eye on that and adapt your program as necessary to keep the pain low. If they can tolerate prone or side lying well, those are great positions to start soft tissue mobilizations to help curb their autonomic response. Important caveat, some people like massage and will see your therapeutic touch as a positive thing, which can improve their outcomes, whereas others may not feel the same way and it can sometimes have the opposite effect. The most current literature on this topic offers varying levels of confidence as to the benefits of soft tissue massage for patients with acute back pain. So proceed with caution and weigh your options. Before you put your hands on your patient, make sure you have their consent and their willingness to participate. It's all about setting yourself up for success, my friends. If you're not confident in your hands or believe they will do better starting with low intensity movement, you almost always want to start with a neutral spine. Hook lying is an easy way to get there. You can also prop up the thighs to take that concept a bit further and decompress their spine if this is something you've determined can help reduce their symptoms. From here, you can start basic movements like lower trunk rotations or pelvic tilts in a relatively pain-free range and direction. You have many options here, but the idea is to get them to start moving. Most movement begins at your spine, so if your back is hurting, initiating most movement becomes a bit more taxing. Because of this, fear avoidance behaviors are very common in people that have low back pain. This is one of the first things you want to address, along with educating the patient about pain science. If you can show your patient that they can move along one plane, get up out of bed without making their symptoms worse or even reduce their symptoms with movement, that's a huge win. Building a positive relationship with movement will improve their compliance and ultimately their outcomes. No pain, no gain is a term that simply does not apply here, especially with acute low back pain, and even more especially with people that have nerve-related pain. For the first couple weeks, to get the pain down, your strategy will likely be to protect the nerve at all costs, only moving in a pain-free range and direction. You'll want to slowly progress them into the range that you've been avoiding, but that is only after symptoms have come down significantly and normal movement is beginning to restore. This can be tricky when you're dealing with patients that have a labor-intensive job. If this is the case, they may benefit from some time off to work on their health, or if that's just not feasible, wearing a soft brace at work in the short term may help keep their symptoms lower. The sooner you begin to find some feel-good movements for these folks, the easier it will be for them to manage their symptoms independently. The most important thing you should take away from this section is to keep it simple for the patient and give them at least one tool they can use to help control their symptoms on day one. I briefly discussed flexion versus extension bias. This is going to be an important data point to start with when coming up with early exercises for low back pain. Since flexion bias tends to be more common, I'll begin there. You want to have your patient starting out in a hook lying position. If this does not feel great to start, try helping them get their legs up onto a Swiss ball. This can put their spine in a more favorable position. But make sure to keep contact on their legs or the ball to make sure they don't lose control and hurt themselves. From here, you can try small amplitude lower trunk rotations. Usually, they'll prefer one direction over the other, so start there. Stress that this movement should not be increasing pain. If it does, do not push through it. Stop and recover. I like starting with this movement first, as the concept is easy for the patient to grasp. It starts the patient off in a relatively favorable position, and it has a lot of room for progression and regression. Lots of folks start with pelvic tilts even before this, and I think that most of the time, that's not the right move. I believe that pelvic tilts are a great movement to help teach postural awareness, and that it's a super important concept that will be carried into many other exercises. But untrained movers, especially those in considerable pain, will often over-recruit their spinal extensors and hip flexors, which may lead to even more pain. I find that it's better to start off with a more familiar and very low effort movement that you more easily assist the patient in completing. You can also start moving into assisted hip and spinal flexion from this position. Again, I recommend keeping contact with your patient or the ball to help them control the movement and ask them for feedback while you work through it. Find a comfortable range and stick to that. I would err on the side of caution at first and avoid end range extension and flexion, staying in that Goldilocks zone right in between. If you want to turn this into a home exercise and they don't have a ball at home, you can always have them try to sit and slide a rolling chair forward and backward at home. Mileage may vary depending on the severity of your patient's back pain, how smooth their floors are, and the quality of their chair. So this is not one I recommend often, but if they like spine flexion and sitting is not too painful, this is a potential modification you can make. Another great place to start, if your patient tolerates sideline, is to work on open books within a pain-free range. Moving the neck and thoracic spine on the lower back is another way to employ that distal to proximal strategy that we talked about earlier. For this exercise in particular, you want to make sure your patient understands the importance of keeping their spine in a neutral position, using pillows under the neck and between the knees if necessary to avoid excessive lumbar rotation and side bending, and cervical discomfort. Remember, every patient is different, so you have to determine what will work best for them based on your professional assessment. I like these because I can usually find value with at least one of these movements on day one. And they're easy to progress as the patient builds tolerance and learns the movement patterns in their body. When you are progressing the exercises of a patient with low back pain, especially in the early stages, you want to make sure that you are prioritizing improving tolerable range of motion and endurance in their positions of relative comfort. You want to avoid axial compression early on and resistance into flexion, especially combined, as that will create shear forces in their spine that will almost definitely lead to bad times. Remember, keeping pain way down is a priority, especially in the first 2 to 3 weeks of PT. Increasing the range of motion as they can tolerate it is a great way to progress these exercises. And you can slowly start challenging the same movement, but in quadruped. Child's pose is a great movement to work on spinal decompression, and typically an exercise that can be tolerated early on as long as the patient can comfortably get into and out of quadruped. If the patient is beginning to tolerate extension better, I like to pair this exercise with press-ups as a way to begin training spinal stability while also teaching the patient to manage symptoms with movement. Building strength and helping the patient develop movement strategies to properly execute functional abdominal exercises is vital, but it is not something that you should start with when the patient's reactivity is still high. You want to recover as much pain-free mobility as you can before you get into strength training. And when you do, I recommend beginning with isometric, low-intensity exercises as they tend to be the least aggressive. And we still want to prioritize keeping the pain low so the patient develops a good relationship with movement and exercise. Going from your didactic training to your first clinical as a PT student can be a challenging experience. It might feel like the training wheels have come off, and when you have your first ever patient in front of you, you may get so lost in making sure you're hitting all the steps you've been taught that you miss the woods for the trees. I think it is important to focus on the big picture on your first day with the patient. Of course, you should screen for red flags. For sure, if something looks fishy, you want to make a note of it and explore further, but don't get caught up in all the details on day one. If you take anything away from this video, let it be this. Establish the following on your first day with a new back pain patient. Determine if they are a good candidate for PT or if they need to be referred out. Educate them about pain science, their prognosis, and what PT can do for them. Prove it to them by helping them see even marginal improvement on day one. Set them up for success by designing an exercise program that works to their strengths and avoids exacerbating their symptoms like we discussed earlier. If you can do these 4 things, I would call that a successful day one. Have faith in your skills, and if you ever get lost in the sauce, just know that your CI, colleagues, faculty, and staff from your university want you to be successful. So don't be afraid to reach out to them and ask for advice. If you have any questions or want to discuss any of your experiences with back pain, comment below and I'll be happy to jump into the conversation. Thanks again for tuning in, and I hope you found some value here today. See you next time.